Welcome back to Mapping Healthcare on KDRT 95.7 FM in Davis, California, where a medic with a map explores healthcare around the world, highlights people who improve it, and shares what we can learn from them. This is your host, Dr. Sheikh. Sam is 80 years old. He's struggling to breathe because of a flare-up of heart failure. He's in the emergency department. It's loud, it's bright, and the doctor says he needs to be admitted. But instead of the usual, we have a bed on the 4th floor, they ask, how would you like to be hospitalized in your own bedroom? In today's episode of Mapping Healthcare, we're talking about hospital at home. Back in the mid-90s, doctors at Johns Hopkins noticed something heartbreaking. Many homebound seniors were actually refusing to go to the hospital. They were terrified of picking up an infection or getting confused and delirious in a strange place, which, to be fair, is a real risk for older adults in hospitals. So these doctors started patching together care plans to keep them at home, which eventually grew into the organized hospital-at-home model we see today. So how did we get from patching things together to this being a global trend? It actually started in the United Kingdom in the late 1970s, before Dr. Bruce Leff pioneered it at Johns Hopkins in the United States around 1995. For decades, it was a niche concept used by a few places like Veterans Affairs medical centers. Then 2020 happened. The COVID-19 pandemic was the ultimate catalyst. Hospitals were overflowing and governments realized we needed hospitals without walls. In late 2020, the US government passed waivers allowing hospitals to get paid the same amount for treating you at home as they would if you were in a brick-and-mortar bed. Suddenly, the floodgates opened. We went from a handful of programs to over 300 hospitals approved for the waiver by 2023. So there's no place like home, but is hospital-at-home care actually safe? You're probably picturing a visiting nurse just stopping by once a day. But it's way more intense than a standard home health visit. Instead of bringing the patient to the hospital, you're bringing the hospital to the patient. And the important point here is the full substitute. It's a comprehensive program designed to completely replace a hospital stay, giving you the exact same level of care you'd get on a medical floor. You're basically in a virtual unit of the hospital. You get transported home, sometimes by ambulance, and you have 24/7 access to a clinical team. We're talking daily visits from healthcare providers, oxygen, IV medications, and even portable x-rays and ultrasounds brought right to your door. And it really does take a village to make this work. It's like they pack up the entire support system of a hospital and set it up right in your living room or bedroom. And do the data hold up? Studies show hospital at home can reduce costs by over 30%. But more importantly, hospital at home patients had a 26% lower risk of being readmitted to the hospital later. Return trips to the emergency department were cut in half, and patients recovered faster. So this shows it's not just cheaper, it's actually more effective at keeping people healthy after they get over that initial illness. Patients are more active and less likely to suffer from delirium, a huge problem for seniors in hospitals. And they're more likely to be satisfied with their healthcare. Our guest in today's episode of Mapping Healthcare is Associate Professor Michael Montalto, Medical Head of Hospital in the Home Unit at Epworth Healthcare in Melbourne, Australia. The views expressed on the show are mine and those of my guests. So Michael, welcome to Mapping Healthcare. You're the unit head of Hospital in the Home at Epworth Healthcare. It's a large non-profit hospital group in Melbourne, Australia. So tell us, what clinical outcomes have you observed in your hospital at home program there, and how do they compare with traditional inpatient care?
Well, hi. It's nice to be here. Our aim in Hospital in the Home is to substitute for acute inpatient care. That's what Hospital in the Home is about. And so it's not only about substituting the technologies and the people that you would normally find in a hospital, but it's also about substituting the outcomes. So what we do is we work very hard to make sure that a patient who comes into hospital in the home achieves the same outcomes that they would expect if they were on the ward, the bricks and mortar ward, the BAM. And we select our patients to make sure that we are going to achieve those outcomes in that select group of people. So we do achieve, I think, very close to, if not the same, if not in some cases, better outcomes for our patients in hospital in the home than the equivalent in the hospital, remembering that we choose our patients.
I'm sure there are, trust issues that some patients might have, families of people that are sick that are trying out this model for the first time. And so let's talk a little bit about that. So before your current job, you worked in the public sector as the director of the Royal Melbourne Hospital in the Home and the Frankston Hospital in the Home programs. And you developed and introduced this model to each of the 3 hospitals you worked in so far and have personally managed over 25,000 patient admissions in acute hospital and the home care settings. So how do patients and families in these programs perceive the hospital at home approach? How do you work to build trust in these sorts of programs?
So firstly, they're hospital programs, they're not community programs. So when a patient is approached by hospital in the home, they're being approached by the hospital and it's a unit of the hospital. So it's important to know, it's important for the patients to know that their care is not being separated from the hospital. It's merely being transferred to another part of the hospital. And so they're being cared for by hospital doctors, hospital nurses, and they're being essentially moved from one part of the hospital to another. So there is some inherent faith in the badging that comes with that. And so there's a slight difference between patients, preps, and carers. Patients, I think, are more inherently amenable to hospital in the home because they're the ones who are experiencing what's going on in the hospital ward. And I think when you present them with an alternative, they see the staff who come and approach them and assess them for hospital in the home care, they ask their questions. There is a level of faith there that we will do the job because they've seen us and we're part of the hospital and because they want to be not in the hospital ward if they can help it. With carers, it's a little different. I think with carers, there is a little more caution and they often reserve judgment until they see the service being delivered. But once they see that we're delivering what we say we're going to deliver, then they become very reassured. And also with regard to both the family and the patient, we ask them to do nothing. So they're not required to input anything into the care. We do it all. And we reassure them that we're on call all the time. So they're not just getting a visit a day, they're getting 24/7 coverage. The analogy I always like to use, both to families and patients, but also to other clinicians, referring clinicians, is to consider hospital in the home a little bit like ICU, but at the other end of the spectrum. You're coming into a specialist unit, a part of the hospital that manages people at a certain part of their illness. We have some tools, we have some staff, we know what we're doing. We'll look after you while you're suitable for us. And then when you're not, either you're too sick, you'll come back to the hospital, or when you're well, you'll be discharged from hospital. And that story, that message is consistent, and I think it's accepted by patients and their families.
That's a great way to communicate the benefits of this model and also the way the model works to patients and their families. Let's talk a little bit about things at our end in the healthcare system, for example, quality of care and patient safety. So you graduated from med school at the University of Melbourne and you also completed a PhD there focusing on hospital and the home care. So you've been really heavily involved in clinical care and policy, research, and advocacy in this area since the 1990s. And you were first appointed medical head of a hospital and the home unit back in 1994. So you've had over 3 decades of experience in this model. So how do you ensure care quality, patient safety, rapid response capacity when delivering acute level care outside the hospital walls?
The way that the hospital delivers it, it's usually the answer to most questions that are put to me about hospital in the home is to reflect back on how hospitals would expect to deliver that care and then base the response on that. So it became very apparent to me very, very early that if we were going to stick to our aim of acute substitution, that is only taking people who would otherwise be in hospital, then you have to be ready to respond to events that are unpredictable. And even if you select patients that are at the more stable end of their hospital stay or have a more stable, presumed more stable episode. You and I both know as clinicians that we don't have crystal balls, and hospitals are primarily there, to catch the unexpected. So you have to be prepared for that. So what we do is, firstly, we employ more skilled people than you would otherwise find on the ward. So people who have more experience and who can assess patients a little more inquisitively and closely than you might find on the average ward. So we select our patients firstly. We have more experienced staff. We round on our patients every day. So our patients are seen physically every day by nursing staff. Groups of them are seen every day by our medical staff based on what they're like, whether we see any problems emerging, what their labs have shown, and what they're telling us. And then we provide 24/7 cover for those patients. Now, some of that is not just reactive on the patient's end. That is to say, where the patient calls us with a problem, we have strategies whereby, for example, we can prompt phone calls to patients where we're concerned about a particular issue. The other thing, I guess, is more, art than science, where I explain to my nursing staff in particular who are new to hospital and home, the thing about hospital and home is you have to set your threshold for a response lower than the ward. In the ward, you can let a lot of things go through to, as we say, go through to the keeper, let them pass because there's people around all the time. In hospital and home, you have to be a little more acutely sensitive to issues that the patient's raising and bear them in mind and be prepared with a plan B and a plan C, because those little things can turn into big things. And so our staff are a little more acutely aware of patients' conditions and will respond to things that perhaps on the ward we wouldn't respond to. So between doing labs, visiting people physically, visiting people virtually, be rounding on people every day, if not twice a day, all the things that you would expect on a ward, we provide pretty good care and are very responsive to deteriorations. And then, of course, it's how we respond when there is a deterioration as well. And so it's a fine balance between extending our care to patients who have got an unexpected issue where we can manage that issue at home and not bring them back to the hospital, or bring them back to the hospital for investigation and a brief period of observation, or escalate them back to the hospital as an inpatient back on the bricks and mortar ward. And it's as important to bring a person back at the right time as it is to deal with the problem at home if we can safely do that. And so one of the measures that we use for the quality of our ongoing care is that notion of unplanned escalation back to the hospital, where we've assessed a patient, we've accepted them, we've been looking after them, something happens, they have to come back to the hospital. And that's an important quality measure that we routinely collect and that we're starting as a group to routinely report so that our models will report rates of unplanned escalation back to the hospital as a way of just describing the way we respond to unexpected events. That rate can't be zero, because if we brought nobody back to the hospital, we wouldn't be looking after sick people. But clearly, nor can it be 20%, because if we're bringing back a fifth of everyone we take, then we're clearly not assessing people properly, or we're clearly not managing people through the day. So it's an interesting and kind of technically difficult job. I mean, hospital and home is in fact a very complex and difficult intervention, really.
As you were describing this, I can understand the fine balance between the kinds of patients that are appropriate for this type of care. You're the executive advisor to the Australasian Hospital and the Home Society. So you're at the cutting edge of advances in this field in Australia. What technological infrastructure, such as remote monitoring or telehealth or in-home services, do you think is really essential for a successful hospital-at-home program?
Well, before we get to the technology, it's about structuring models that reflect the kind of intervention that I just mentioned. So it's about having medical staff and nursing staff who are dedicated to hospital and home and work in hospital and home for hospital and home. So it's a kind of closed unit model of the way we approach care, where patients are given to us to manage, and we manage them because we're good at managing it. So having that structure is very, very important. And you need that before you're going to introduce any technology, because if you don't have a very good firm clinical governance structure, clinical management structure within the unit for that group of patients, then any technology that you're going to put in is just not going to match the outcomes that you want. If you have that structure, then sure, there are emerging remote patient monitoring and telehealth tools that will help. But I've put that expression deliberately. They are tools that will help. They are not platforms that will deliver hospital in the home in and of themselves, because they can't. What they do is they allow us an extra eye so that we don't necessarily have to send a physical person out to do a set of vital signs whenever there's a deterioration or a problem. Most remote patient monitoring and a lot of telehealth has been introduced in the context of chronic disease management, and we are not chronic disease management. And also, let's be frank, most of the patients in your hospital and mine, they're monitored by human beings, but they're not monitored by technology. The need for remote patient monitoring is something that Hospital in the Home is teasing out at the minute. And I think many people are falling back on the idea that ad hoc clinician-initiated monitoring is going to be a useful thing, but how much of it and in what form is kind of still unknown. And the patient's acceptability of a lot of remote monitoring is still also open for question. They're going home because they don't want to be in the hospital. And if you start remote monitoring them in ways that are invasive, they may not accept hospital in the home, because that's why they're at home, to be not like that. And finally, there are just the technical issues. As I said, a lot of these things were adapted for other purposes. So their physical adaptability for hospital in the home is still not necessarily great. And their own ways of measuring their own quality is still not advanced. It's very hard to come to a measure of how effective remote patient monitoring is, how acceptable it is. There isn't a lot there for us to use. So we're actually in the front of that, I think, in terms of assessing those technologies. And all that work's going on right now in different hospital and home models around the world, particularly in the United States. And we will arrive in time to an assessment of what is useful about those technologies, what those technologies should look like for the purposes of hospital in the home. We're not quite there yet, but I think we're making great steps to get there.
Yeah, and you mentioned a really good point about, the humans in hospital at home being the primary drivers of making this work, and the technology being a tool that supports these humans. So how do you coordinate the interdisciplinary teams in this setting? I can see nursing playing a part, hospitalists, pharmacists, paramedics, home health aides. How do you coordinate this range of expertise and these various groups of people within the home-based environment?
So I think Ginger Rogers once said that she did everything Fred Astaire did, but backwards and in high heels. And hospital in the home does everything the hospital does, but with the added logistic burden of not having the patient physically there. So it's a little bit like that. We try to replicate the hospital model as much as possible, so that whatever we can do without being in front of the patient, we do. But there are logistical difficulties in getting some of those things out, and it forms a big part of our job. So we bring together those resources, we package them up, and we deliver them as we can. It's very difficult to explain that very briefly, because the mud map is kind of very complicated, but our patients do need pharmacy input. Does that mean the pharmacist has to physically go out there? No, but they do need pharmacy input, and we coordinate ways of making sure that the pharmacy service is streamlined and responsive and deals with the challenges of delivering drugs to us that sometimes are not in the same form that they're delivered to patients in hospital, in a timely fashion, so they can be transported, so they can be administered and dispensed to patients in their homes. The same with allied health inputs that go with acute care, and the same with nursing care, and the same with medical care. And how we coordinate it is we round on our patients, we bring those resources together in ways that we best find most efficient, and we deliver them. And they're all a little unique, and each unit will have a different way of adapting to those needs, but the components are all still there.
You gave the dance analogy, right? Like the dance partner analogy that you mentioned. And the same sort of dance that we do with the various humans that help make such a model work also happens with health systems and payers. And so, you were hospital at home international fellow at Ariadne Labs at Brigham and Women's Hospital and the Harvard T. Chan School of Public Health in Boston. There, I'm sure you've worked on looking at how such programs perform and manage risk and show value to health systems and payers so that they continue to be supported and funded. What did you learn from some of your work in this area in working with other partners that help support such models?
And firstly, it's been very good news for those of us outside the United States that the United States has, over the last 3, 4, 5 years, introduced hospital in the home on broadly the same terms and under the same broad definitions and the same broad inclusion criteria that we have in the rest of the world, which is that it's a hospital inpatient service and it's recognized as an inpatient service and reimbursed as an inpatient service. And the United States has been more, in a sense, inquisitive, perhaps a little more disciplined in its approach in terms of what it's asking for. It's been a little more firm in its definition of inputs for hospital in the home, which I think is a good thing from a payer's point of view, but also from a hospital's point of view, because it's the hospitals that have to be both convinced and guided along the path of hospital in the home. I think, interestingly, in hospital in the home, the payers have been looking for this alternative for a long time. And you'll ask, well, why? Why would they pay the equivalent amount or close to the equivalent amount for a hospital in the home service to an inpatient bed service? And I think primarily the economic argument for hospital in the home is not necessarily in its recurrent costs. I mean, I've just tried to explain in a very ham-fisted way that it's actually logistically a very difficult thing to do, and probably a very unnatural and in some ways inefficient thing to do, to take a patient home and give them their acute care. So in terms of recurrent costs, it may be a little better, but it's not vastly better than being, the 41st bed in a 41-bed ward. But what hospital in the home does is it builds hospital beds much, much more efficiently than bricks and mortar, much more efficiently. So when payers are looking at constrained systems, which are not just constrained and expensive to build, but very inflexible. When you build a 300-bed hospital, you've built a 300-bed hospital. And when you have demand that needs 350 beds, you can't do that in under 3 or 5 years and $3 million a bed, at least in my country. So payers don't know what to do about that problem, and hospital in the home has a solution. And in fact, COVID tested that solution. So when COVID came, what hospital in the home could do was expand the capacity of bricks and mortar hospitals, not just by taking COVID patients, but by taking non-COVID patients in ways that no one could do before. And the vision of health system planners that you can suddenly transform gyms and football stadiums into hospitals is a fallacy. It just can't be done anymore. Whereas hospital in the home, if it's properly done, gives you that ability to flexibly grow your inpatient capacity without the capital requirements. And I think payers understand that. I don't think hospitals yet are convinced and understand that. I don't think all hospitals think yet that this is the way of their future, and they need to be convinced of that. And I think both the payers and now the clinicians that are growing, if you like, a discipline called hospital in the home, will bring hospitals to the realization that some of their work is not going to be based in bricks and mortar. I think payers have been relatively patient in terms of seeing what we can do. I think the fact that we are mostly still within the hospital system for reimbursement means the data that they can get on what we do comes from the hospitals, which is with no disrespect to the community service providers, but the data that's collected on a hospital in the home patient is the same data that's collected for any other hospital ward patient. So you can extract that. You know when they were admitted, you know when they were discharged, you know what inputs they had in terms of nursing hours, medical hours, pharmacy costs. You know what kind of ICU stays you had. You know if they died. You know what their discharge destination was. And you know if they were readmitted 28 days after they were discharged. So all that data, for the way hospital home is constructed within the hospital system, gives payers the ability to actually assess what's going on. Now, they will be concerned that the threshold for admission is lowered. And the challenge for us is to make sure that doesn't happen. So we need to demonstrate to payers that the threshold for admission into hospital home is the same. That's a more challenging question. We can certainly demonstrate outcomes, but in terms of who comes into the unit, we need to give some assurances. And I think, in the United States, you can't come into the hospital and home service, unfortunately, directly from the community. You have to come from the hospital. So someone else in the hospital makes that decision. And that's mostly the case So someone else in the hospital who says this patient needs to be in hospital, but I'm referring them to hospital in the home, that gives payers some assurance. It does unfortunately cut you out of people for whom it's very difficult to come into the hospital. So if you're in a nursing home facility, as we call them in Australia, so you're bedbound and it's very difficult to transport you into the hospital. In my country, you have the ability to be admitted directly into hospital in the home. In the United States, you don't, and you probably should. But I can understand payers still getting to terms with what this is and what the likely numbers are going to be and what the onus on funding is going to be for them. But I think that having the hospital-based data will reassure them in terms of what that exposure might be.
So, Michael, we end each episode of Mapping Healthcare by talking a little bit about the place our guest comes from. You live in Melbourne, Australia, so tell us a little bit about a couple of places or activities, bricks or mortar otherwise, in Melbourne that a person new to the area should check out.
Well, it's the last weekend of January, so I don't know if you're a tennis fan, but this is the last weekend of the Australian Open, which is played in Melbourne. So the women's final is today and the men's final is today. And so we're in the middle of summer, and the Australian Open kind of signifies a very kind of laid back time in this city where people are still in the middle of summer enjoying the return of sporting events and the return of normal life. What can I tell you about Melbourne? It's a very large city in a very big continent, and it's a nice place to visit. I guess it perhaps doesn't have all of the beauty and charms of our northern rival in Sydney and Brisbane, which is close to some very, very beautiful parts of the country. We're more a kind of business and educational hub of the country. And yeah, I mean, that's kind of Melbourne. I've lived here all my life, and it's a long, long way to come and visit, but I hope it's worth the visit.
Clearly, it's home to innovators such as yourself. So I really thank you for your time, Michael, for sharing your experience in hospital at home models with our listeners. I do appreciate the time you spent with us today.
Well, thank you for the invitation. It's always nice to talk about hospital in the home. I do it a lot, but it's my first time on a podcast, so that's been very interesting, and thank you for the opportunity.
So that was Dr. Michael Montalto telling us about his decades of experience with helping patients be homeward bound in Australia. Hospital at home programs sound like a winner, but are there any downsides? Current models often require you to go through an emergency department first to qualify. There's also the gaming concern. Hospitals could potentially use this for patients who aren't actually sick enough for a hospital bed just to get those higher payments. And we can't forget caregiver stress. While some studies say it's lower because the family is more comfortable, others worry we're just shifting the burden of care onto families. So as we wrap this episode up, here are some of my big takeaways. First, home is often a safer hospital for seniors. By avoiding the brick and mortar building, you're cutting the risk of hospital-acquired infections, falls, and the functional decline that happens when you're stuck in a hospital bed. Second, the future of hospital at home, especially in the United States, depends on policy. Whether this becomes a permanent part of how we do medicine depends on if insurance continues to pay for the hospital even when there are no walls. And finally, technology has been a game changer. We've moved from just a phone and a nurse to biometrically enhanced video visits and wearable sensors that track your vital signs in real time. This tech is what makes high-level care possible outside the hospital ward. At the end of the day, a lot of experts see this model as the future because it hits what's called the triple aim of healthcare. It increases access to care, improves the quality of that care, and it reduces the cost. And it's incredibly rare for a single idea to come along that delivers on all three of those goals so well. It turns out the best medicine might just be a dose of your own home. Thanks for tuning in. This was your host, Dr. Sheikh. You were listening to Mapping Healthcare on KDRT 95.7 FM. Connect with the show on Instagram at Mapping Healthcare if you'd like to share your thoughts and ideas for future episodes or guests. You can hear Mapping Healthcare around the world anytime on kdrt.org and wherever you get your podcasts.